everyone. Thank you very much for watching. Welcome to researchmd.com. Today we're going to talk about a very important topic, necrotizing fasciitis. Again, my name is Pramil Cheriyath. I'm a physician. I teach medical students and medical residents, program director, internal medicine, transitional residency, also an assistant professor of medicine, Hackensack School of Medicine. So, necrotizing fasciitis go long way back. I'm talking, during the time of Hippocrates. He described many were attacked by the erysipelas all over the body when the exciting cause was a trivial accident. Flesh, sinews, and bones fell away in large quantities. There were many deaths. It signifies the importance of necrotizing fasciitis. The death rate and the mortality is extremely high in necrotizing fasciitis. Then they said there were many deaths. That means we have to take this very, very seriously, right? So if you look at the first thing, we need to look at the definition. It's necrotizing fasciitis are rapidly progressive. When I say rapidly progressive, it can spread through the fascia like 1 inch per hour. In secondary necrosis, causing necrosis of the subcutaneous tissue. The speed of spread is directly proportional to the thickness of the subcutaneous layer. Unfortunately, even our overlying skin may be completely normal. We may not understand there is this huge, serious damage going over underneath the skin. So what necrotizing means, the causing death of tissues. Fasciitis means inflammation of the fascia. Incidence, approximately 1,000 cases per year, 0.04 cases per 1,000 person per year. But once the patient develops necrotizing fasciitis, the risk of death is kind of extremely high. It can go up to almost like 80, 70, that range. Okay. And so there's some classification, anatomic location. Okay, the terms you need to know is like a Ludwig's angina. Anytime there is submandibular space in the cervical region, that is actually classified as Ludwig's angina. And the other one, if there's an abdominal necrotizing fasciitis, they call Melanes. And then the last one you have to remember is like the Fournier's gangrene in the perineum or scrotal in the perirectal region. You have to, it's kind of classified as Fournier's gangrene. Depth of infection, you got necrotizing adipocytes, fasciitis, and myositis, and microbial class based on that type 1, type 2, type 3, and type 4. Okay? So classification, type 1 is the most common type, is polymicrobial, causative organism, gram-positive, gram-negative, and the anaerobe. So that's why we cover everything. It's very important, empiric coverage with the gram-positive, gram-negative, and anaerobic. Then the type 2 is the monomicrobial, is the group of streptococcus and staph involved. And type 3 caused by Vibrio vulnificus. Sometimes, you've been in the water, have an injury. Type 4 is caused by the fungus, rare. Now, what is the pathophysiology? Let's look at what happened in the Staph aureus and streptococci. They elaborate this M1, M3 proteins. This M protein, it make the microbes ability to adhere to the endothelium, and then so it can escape the phagocytosis. Okay, and they also have the surface proteins like exotoxin A, B, C, and streptolysin O. They damage the endothelium, escape. That can make escape the plasma. This causes tissue edema. They also stimulate the CD4 cells and macrophages and large number of tumor necrosis factors, alpha, IL-1 and IL-6, and cause systemic release. And then you have the systemic inflammatory response syndrome, and the patient goes into shock. This is what, in a nutshell, that's what happened in molecular basis. So what do you look for when the patient come in? Pain out of proportion to the exam, beyond confines the skin, and erythema. Okay, pain out of proportion, severe pain, and then you see the skin changes, and above that and above the borders, you will also see edema of the tissues. There's a bulle or cutaneous necrosis, always like bilaceous bulle lesion. Be careful. Tense edema extending beyond the margin of erythema. Again, that's a very classic sign. Gas in the subcutaneous tissue. How do you feel it? You try to palpate and you can see the crepitance, right? Loss of sensation in the affected area. Signs of systemic toxicity. Rapid progression of erythema and changes despite antimicrobial therapy. Again, when I said this is the most dangerous thing, the rapid spread underneath the skin by the time we realize it may be like too late, 1 inch per hour. So there are reports, the patients, they come in with maybe some shoulder injury and then kind of develop necrotizing fasciitis. In 45 minutes they were dead. Labs, CBC, CMP, the usual lab work, but also you want to add the PTINR, inflammatory markers, see reactive protein ESR, check the lactic acid, CK and AST. That can tell you about the muscle damage, okay? So when we come in, the other thing we can do radiography. Easiest thing to do is like an X-ray. Even though it's not a very sensitive test, you can look for the air in the X-ray. CT scan with the contrast, you got a 94% sensitivity and 77 specificity. MRI is probably the pretty good test. You can get up to 90 to 100% sensitivity, specificity up to like 85%. To diagnose it. Now, once you diagnose, and if you're any patient come in with a cellulitis, you should use this score called laboratory risk indicator for necrotizing fasciitis. So you plug in all these numbers like hemoglobin, white cells, sodium, creatinine, glucose, and C-reactive protein. If the score is like 6 to 7, there's an intermediate risk. If it is greater than 8, 75% risk. So always use a risk stratification when you treat or when you're suspecting, or even if a patient come in with a cellulitis, always think about the score, calculate the score, so estimate your risk for necrotizing fasciitis, okay? Now, treatment, the number one thing is always number one, don't waste your time. If you suspect necrotizing fasciitis, always call surgeon. Pick up the phone and call them right away. Surgical debridement, the longer you wait for surgical debridement, the risk of death goes higher and higher, okay? IV antibiotic cover gram-positive, gram-negative, and anaerobes coverage. A good empiric coverage or something. You can start with the carbapenem, vancomycin, and clindamycin, or you can start with the zosyn, vancomycin, and clindamycin, okay? There are reports about IVIG treatment is also helpful. Some studies have shown benefits, some did not. Hyperbaric oxygen therapy also has a role in it. So again, necrotizing fasciitis is a serious infection. Anytime a patient come to the emergency room, the first question always ask is like, does this patient have necrotizing fasciitis? Okay? Thank you for watching. Please subscribe to our channel. We'll be back with another great presentation later.